Imagine a condition that, well, permanently alters human anatomy.
Yeah.
A disease that literally fuses skin together, causing just excruciating pain.
Yeah.
And it affects roughly 1 in 80 women.
Right, which is a staggering number.
It really is. And yet, I mean, if someone develops this, they're likely going to walk around undiagnosed for an average of 5 years.
Half a decade.
Yeah, half a decade living in agony simply because the condition is so shrouded in embarrassment and the medical community just routinely misidentifies it.
It's the definition of diagnostic muddy waters,
Yeah.
honestly. We're looking at a disease that completely hides in plain sight.
Yeah.
And the collateral damage, both physical and psychological, of that 5-year delay is immense.
And that's exactly our mission for today's deep dive. We are unpacking a massive stack of clinical guidelines, dermatological journals, and patient support data to answer 2 vital questions.
Right.
What exactly is this master of disguise known as lichen sclerosus, and, what actually causes it?
And we should probably establish right up front, this deep dive deals with intimate areas of the body.
Yes, it does.
But the goal here is to strip away the stigma and really empower you, the listener, with factual knowledge.
Exactly.
Because the underlying science of how the body interacts with itself, how the immune system can just suddenly turn against its own architecture, is incredibly complex. There is absolutely no room for embarrassment when we're decoding human biology.
So true. So let's start with the physical reality. Before we get into the, systemic causes, what actually happens to the skin when someone develops lichen sclerosus or LS?
Well, in a clinical sense, LS is a chronic non-contagious inflammatory skin disorder.
Okay.
But what it actually does is completely transform the texture, the elasticity, and really the whole appearance of the tissue.
Right.
The affected areas turn into these very distinct white, shiny, crinkled patches. The clinical literature actually frequently compares it to wrinkled tissue paper.
Looking at the dermatological photographs in the sources, the comparison that immediately came to my mind was old parchment paper.
Oh yeah, that's a great way to describe it.
Because, healthy skin has an elasticity to it, right? It
Yeah.
stretches, it bounces back because of collagen and elastin. But with LS, the skin just loses that structural integrity.
It does.
It becomes rigid and incredibly fragile. It looks like it would tear at the absolute slightest movement.
And it does tear. I mean, the surface essentially loses its ability to endure normal mechanical stress.
Wow.
Visually, you'll see this sort of ivory color to these patches. And in some areas, the body reacts to the damage by overproducing skin cells, which leads to thick, leathery patches.
Okay.
That process is called hyperkeratosis. But right next to that thickened skin, you have the parchment-thin areas.
Right, the super fragile part.
Exactly. And because those thin areas are so fragile, you frequently see tiny purple blood blisters pooling just under the surface.
Oh.
Yeah, they're called ecchymoses. And they happen simply because the microscopic capillaries are rupturing from just everyday movement.
It's just devastating to the tissue. And where is this parchment paper skin actually showing up?
Well, primarily, the clinical data focuses on the genitals.
Okay.
In women, it very often forms this figure-of-8 pattern, sort of looping around the vulva and extending downward to circle the anus.
Right.
In men, it primarily attacks the foreskin and the head of the penis.
Though in men, it's sometimes called something else.
Yeah, it's sometimes referred to by a much older, rather intense clinical name, balanitis xerotica obliterans.
That sounds intense.
It does, but it's the exact same pathological process.
But, the sources revealed something that completely shifts how you have to look at this disease.
Extragenital cases.
Exactly. It doesn't only affect genitals. Anywhere from 6 to 20% of patients develop what's called extragenital LS. They get these exact same white, dry plaques on their thighs, their lower back, under their breasts, or even on their shoulders and armpits.
Which is such a crucial clue. Because if you have a patient with a white, crinkled plaque on their shoulder, it completely rules out the idea that this is just some localized reaction to, say, a genital soap or a specific type of underwear.
Right. It's not just a contact allergy.
Exactly. It proves we are dealing with a systemic vulnerability. The entire skin organ has this systemic glitch, but it's choosing to express itself in these highly specific localized zones.
And the physical symptoms that come with this glitch go way beyond a cosmetic change or simple rash. The daily reality for these patients is incredibly severe.
It really is. The overriding symptom, the one that drives patients to the point of absolute distraction, is pruritus.
Which is the itching.
Yes, an intense, deeply set itch, and it's almost universally described as peaking at night.
Oh, that's awful.
We're not talking about a mosquito bite here. We're talking about an uncontrollable neurological signal that just demands to be scratched, leading to severe sleep deprivation.
And because the skin is like that fragile parchment, the sheer act of scratching, which they literally cannot stop themselves from doing in their sleep, causes the skin to fissure and tear open.
Yes.
That leads to constant rawness and soreness. Naturally, it makes sexual intercourse agonizing, which is a condition called dyspareunia.
Right.
But the symptom that I found most shocking was the anatomical distortion. The sources talk about the tissue literally fusing together. How does an itch lead to parts of the body just disappearing?
It's the chronic inflammation. When the skin is locked in a state of severe, unrelenting inflammation for months or years, it actually destroys the normal cellular architecture.
Wow.
The body is essentially trying to heal constant micro tears, and it does that by laying down scar tissue.
Okay, that makes sense.
So over time, in women, the labia minora, the inner lips, can completely resorb. The tissue just flattens out and blends right into the surrounding skin.
That's terrifying.
The clitoris can become entirely buried under its hood as the skin fuses over it, trapping it. And the entrance to the vagina can severely narrow, a process called introital stenosis.
So the body is essentially shrink-wrapping itself.
Exactly. The scar tissue contracts. And in men, this scarring causes phimosis, meaning the foreskin becomes rigid and impossible to retract.
Right.
It can also travel down and narrow the urethra, making the physical act of urination incredibly difficult and painful.
Oh, wow.
And this isn't just an adult problem. In pediatric LS, which happens in young children, they often get it perianally around the anus.
Which means every time they go to the bathroom, the skin is tearing.
That's agonizing. So the child subconsciously holds it in. They refuse to pass a bowel movement, which leads to chronic, severe constipation.
Oh, that is so sad.
Pediatricians will sometimes treat the constipation for years without ever checking the skin to see that the child is actually avoiding the toilet out of sheer terror of the pain.
Wait, hold on. You're describing a disease where tissue is literally resorbing, skin is fusing together, and the pain is so bad children are holding in their bodily functions.
Yeah.
How on earth does someone walk around with this for an average of 5 years before getting a diagnosis? How does a doctor not step in immediately?
Well, it exposes a massive flaw in how we handle intimate health. It's a cascading failure of stigma, embarrassment, and outright misdiagnosis.
Right.
Patients are conditioned to not talk about genital discomfort. They assume a chronic itch is just poor hygiene or maybe just a normal, unfortunate part of aging or menopause, so they suffer in silence.
And they just buy over-the-counter creams, hoping it goes away.
Right. And when the pain finally overrides the embarrassment and they go to a general practitioner, the doctor often gets it wrong.
Really?
Because the presentation involves itching and white discharge or plaques, a hurried doctor frequently writes it off as a stubborn case of thrush.
Like a yeast infection.
Exactly. Or standard eczema. They hand the patient an antifungal cream, which does absolutely nothing for an autoimmune condition, and send them on their way.
Wow.
The cycle of misdiagnosis can last for years, while the anatomical damage quietly becomes permanent.
So we really need to understand what's actually happening on a cellular level to stop this cycle. We know how the body is breaking down, but why is the immune system doing this in the first place?
To clear the muddy waters, we have to rule out what it's not. The clinical guidelines are unequivocal. Lichen sclerosus is not an infection.
Okay.
It is not contagious. You cannot catch it. It cannot be passed through sexual contact, and it has absolutely zero connection to a person's hygiene habits.
So if it's not an invader from the outside, it's friendly fire. It's
Yeah.
coming from inside the house.
Exactly. Medical science categorizes LS as an autoimmune disease. Your body's defense system gets its wires crossed and identifies your own healthy skin as a hostile threat. The statistical evidence for this is just overwhelming. Between 20 and 30% of women with LS already have another recognized autoimmune disorder.
Oh, really?
Yeah, their immune systems are already prone to these errors. There's a huge overlap with thyroid disease, vitiligo, which is the autoimmune destruction of skin pigment alopecia, and pernicious anemia.
But the clinical data points to a very specific target the immune system is going after in LS.
Yes, the ECM1 protein.
Right. Researchers have found antibodies against this specific protein called extracellular matrix protein 1, or ECM1, in roughly 60 to 80% of women with vulval LS.
Right.
What is ECM1 doing that makes its destruction so catastrophic for the skin?
Well, think of the extracellular matrix as the biological mortar between the bricks of your skin cells.
Okay, I like that analogy.
It's the scaffolding that holds everything together, providing elasticity, structure, and a pathway for blood vessels to supply nutrients.
Got it.
When the immune system generates antibodies that specifically hunt down and neutralize this ECM1 mortar, the bricks start to collapse.
Oh, wow.
The skin cells literally detach from their underlying structural support. That's why the skin loses its elasticity, thins out, and takes on that fragile, crinkled parchment texture. The structural foundation is literally being dissolved.
But looking at the research, there's a huge debate about this. Like, are these ECM1 antibodies actually the cause of the disease?
That is the big question.
Are they the frontline soldiers initiating the attack, or are they just the cleanup crew reacting to the wreckage? Because, I mean, if something else damages the skin first, wouldn't the immune system just create antibodies against the debris?
That is the million-dollar question in dermatology right now, and you've hit on a major controversy. A lot of researchers argue these antibodies are epigenetic,
Meaning what, exactly?
meaning they're a downstream result of the tissue damage, not the root cause. The theory is that some initial unknown trigger damages the tissue, which spills this ECM1 protein into the bloodstream where it doesn't normally belong.
Ah, I see.
The immune system spots it, flags it as foreign debris, and starts churning out antibodies. It becomes a self-perpetuating cycle of destruction. But the ECM1 antibodies didn't actually fire the first shot.
And part of why some people might be susceptible to that cycle is genetics. The sources say 10 to 15% of patients have a direct family member with the disease.
Yes.
So you inherit the vulnerability. But as with most autoimmune conditions, having the genetic vulnerability doesn't mean you automatically get the disease. Something still has to activate it.
Right, you need a catalyst. And the data point strongly to two major triggers: hormones and mechanical trauma.
Let's talk about hormones first.
Well, the demographic skew is massive. Women are 10 times more likely to get LS than men. And if you map out when it typically strikes, it spikes at two very distinct hormonal phases:
Okay.
in prepubescent girls and in women who have gone through menopause.
Both are periods where estrogen levels are incredibly low.
Precisely. It indicates a severe vulnerability caused by a relative lack of estrogen, and specifically, a loss of androgen receptors in the affected genital tissues.
Right.
The skin in that region relies on a steady stream of hormonal signals to maintain its robust thickness and elasticity. When those estrogen levels plummet, the tissue becomes frail and susceptible.
But I noticed a crucial nuance in the guidelines. When you hear that estrogen drops cause the vulnerability, the logical leap is, well, great, just give the patient an estrogen cream or hormone replacement therapy and it's cured.
Right, but it's not that simple.
Exactly. The medical consensus explicitly states that HRT and topical estrogen do not cure lichen sclerosus.
You don't.
They might help with generalized dryness, but they don't stop the tissue from fusing, and they don't halt the autoimmune attack. To me, that suggests hormones are just opening the door. They weaken the tissue, but something else actually walks through that door and starts the fire.
It's an incredibly important distinction. The hormonal shift sets the stage, but you still need an inciting incident to trigger the immune response. And this brings us to one of the wildest concepts in dermatology: the Koebner phenomenon.
Oh, this blew my mind.
It's fascinating. The Koebner phenomenon is a dermatological event where sheer physical trauma to the skin triggers an underlying autoimmune disease to manifest at that exact site of injury.
Wow.
So if you have a genetic predisposition and your hormones have thinned the tissue, pure mechanical friction can summon the disease to that specific location.
The sources gave examples that are just everyday activities, like wearing a tight waistband that constantly rubs the skin, horseback riding.
Yes.
Even a past surgery scar in the genital area can become the epicenter for an LS plaque years later. And terrifyingly, just the act of scratching a normal itch can trigger the Koebner phenomenon. It literally draws the disease to the exact lines where your fingernails scrape the skin.
It completely reframes how we think about the immune system. We usually think of it fighting bacteria or viruses.
Right.
But here, mechanical friction is registering as an injury, and the immune system responds by flooding the area with inflammation that never turns off.
That is wild.
This also provides a compelling explanation for the male presentation of the disease. In men, lichen sclerosus is exceedingly rare in those who are circumcised at infancy. The leading clinical theory relies heavily on this exact principle of localized chronic irritation.
Because uncircumcised men can have microscopic amounts of moisture or urine trapped under the foreskin.
Exactly. Urine contains uric acid and urea. If microscopic amounts are chronically trapped against vulnerable tissue, it acts as a constant low-grade chemical irritant.
Oh, I see.
The trapped moisture essentially acts as the trauma. It micro-damages the skin barrier over years, constantly pinging the immune system until it finally triggers a localized Koebner response.
The idea that trapped moisture or a tight pair of jeans can basically act as a homing beacon for an autoimmune attack is just wild.
It really is.
So, knowing all of this, the genetic vulnerability, the hormonal catalysts, the mechanical triggers, and the destruction of the cellular mortar, how do doctors actually step in and stop the body from tearing itself apart?
Well, the intervention starts with securing a definitive diagnosis. A specialist who knows what they're looking for can often diagnose it visually, spotting the parchment texture and the figure-of-8 pattern.
Right.
But standard practice frequently involves a punch biopsy, where a tiny piece of tissue is removed under local anesthetic and examined under a microscope.
And that biopsy isn't just to prove it's LS, it's to rule out cancer, which is a critical part of this we have to cover.
Absolutely. Once the diagnosis is confirmed, the universal gold standard for treatment across all medical guidelines is an ultra-potent topical corticosteroid.
Okay.
The most frequently prescribed is clobetasol propionate 0.05%. And the word ultra-potent is key here. Patients are often terrified of strong steroids because they are warned that steroids thin the skin.
Right. If the disease is already making the skin paper thin, wouldn't a steroid make it worse?
It's totally counterintuitive, but in the case of LS, the steroid is the only thing that saves the skin.
Really?
Yeah. The disease is thinning the skin because the immune system is destroying the tissue. The ultra-potent steroid acts as a heavy immunosuppressant blanket.
I see.
A tiny pea-sized amount rubbed into the plaques effectively suffocates the local immune response, shutting down the inflammation before it can dissolve any more of that cellular mortar.
The mechanics of the treatment plan really emphasize the chronic nature of the disease, though. When a patient is first diagnosed, the immune attack is completely out of control.
Right.
They use the steroid every single day for roughly 3 months to forcefully suppress that active flare-up. But because it's an autoimmune condition, you can't cure it.
No, you can't.
The underlying vulnerability is always there.
Yeah.
So patients have to transition to maintenance therapy, applying the steroid once or twice a week for the rest of their lives.
Maintenance therapy is absolutely non-negotiable. While the steroid cannot reverse the anatomical fusion or the scarring that has already occurred, once the tissue resorbs, it's gone. It absolutely halts the progression.
Okay.
If a patient stops the weekly maintenance, the immune system will eventually wake back up and the architectural destruction will resume.
That makes sense. It's kind of like fighting a smoldering underground fire. You can put out the visible flames with the daily treatment, but you have to keep regularly watering the ashes for the rest of your life so it doesn't flare up again.
That's a perfect analogy. And alongside the steroids, patients rely heavily on emollients, thick moisturizers, and soap substitutes to artificially protect the compromised skin barrier from friction and urine.
And there is a very severe reason why lifelong maintenance therapy and regular medical monitoring are so critical: the cancer risk.
Yes. The clinical data shows that patients with genital LS have a 3 to 5% lifetime risk of developing squamous cell carcinoma, a serious type of skin cancer, directly on the affected plaques. That is exactly why patients must be monitored by a doctor at least annually. When tissue is subjected to chronic, unrelenting inflammation and constant physical tearing from scratching, the cells are forced into hyperdrive, constantly dividing to try and repair the damage.
Right.
The faster cells divide, the higher the mathematical probability that they will make a genetic error, a mutation that basically turns cancerous.
So, synthesizing everything we've gone through, lichen sclerosus is a master of disguise. It's a chronic autoimmune condition where the body dissolves its own cellular scaffolding, turning the skin into fragile parchment.
Yep.
It requires genetic susceptibility, a hormonal shift, and often a simple mechanical friction to trigger it. And because it literally reshapes human anatomy, it demands proactive, lifelong management to suppress the immune system and prevent permanent damage.
And zooming out, it's just a stark reminder of the danger of silence. The societal stigma around genital health allows a highly treatable disease to masquerade as aging or yeast infection for 5 years, leaving patients with irreversible anatomical changes.
Which is exactly why this deep dive matters. Even if you don't have this condition, statistically, with 1 in 80 women affected, someone in your orbit might be suffering in absolute silence right now.
Very likely.
Understanding that chronic genital pain or unbearable itching isn't just a hygiene issue, and it isn't something to be embarrassed about, could literally save someone years of agony. It's about bringing the biology out of the shadows.
And as we wrap up, I want to leave you with a fascinating biological paradox regarding that cancer risk we just mentioned.
Oh, let's hear it.
We know there's a 3 to 5% risk of squamous cell carcinoma. Now, in the broader medical world, almost all genital cancers, like cervical cancer or standard vulvar cancer, are driven by a virus, specifically the human papillomavirus, or HPV.
Right, the virus invades the tissue and hijacks the cellular DNA. That's the entire mechanism the HPV vaccine was created to stop.
Exactly. But the clinical literature notes something incredible about lichen sclerosus. The carcinomas that develop from LS plaques generally do not contain HPV.
Wait, really?
The virus is completely absent. Instead, when pathologists examine these specific cancer cells, they find severe oxidative DNA damage and mutations in a very specific tumor suppressor gene called P53.
The P53 gene is essentially the guardian of the genome. It's supposed to stop damaged cells from dividing.
Yes, which raises a profound question about the physical limits of the human body. Are these cancer mutations caused by some invisible chemical byproduct of the autoimmune disease itself? Or does the sheer mechanical trauma of years and years of chronic scratching, the constant, desperate tearing and repairing of that fragile parchment skin, literally mutate the DNA over time? Does the mechanical friction force the cells to divide so fast and so often that the P53 gene finally just breaks under the strain?
It's an incredible thought. We always look for the clean external invader, the virus we can vaccinate against, the bacteria we can hit with antibiotics. But the body's internal landscape is so complex, and sometimes the most profound damage comes from the body simply trying and failing to survive its own environment. Something to ponder as you consider how beautifully and sometimes destructively our biology is wired.